It is my great pleasure to introduce to you Dr. Dan Dean from Michigan. We are thrilled to have you here. Hoped to have you last year. Delighted that this year is finally here. Long year waiting for you. Probably more stories for us, though. Thank you very much.
Sure thing. Thank you very much. Good afternoon, ladies and gentlemen. It's a pleasure and an honor to be here. I have been, some of you have met, some of you are familiar with this picture. This is the first animal that I worked with EMU oil. This is one of my racehorses that had a colitis, and we thought we were going to lose him. I'm not sure exactly what happened, neither was the vet, but this horse lost all of its hair. And this was in August in Michigan. It's pretty warm. Lost all of his hair. It was like a sunburn. So you couldn't even touch him. So I had an emu that had something wrong in the brain. He couldn't stand up. So, one of the first ones I bought, and I paid about $500 for it. I wanted to eat the meat, but I was afraid to. But I did take the oil. I rendered the oil. I used to live on a farm when I was growing up, and my father used to render pork fat, so I knew exactly how to do it. You couldn't touch him, but I heated it up, put it in like a Windex bottle, and sprayed it on him for the first 3 or 4 days, and then he finally let us touch him. You've seen this picture before, but this horse finally turned out to be quite a racehorse. All the expense it cost me in the vet fees and everything, he paid it back to me. Next slide. This young man, in my practice, this young fellow is about 14, 15 years old, riding a motorcycle, and they call this road rash. Came into the office. We had cleaned this up. It was a nasty mess when he came in because he'd had this about 2 or 3 days, and we started applying the EMU oil. At this time, I was using a total occlusive dressing. I don't do that anymore. We use a porous dressing, but we still use the 4x4 pads soaked with EMU oil and lay it right on the wound itself. Next page. And this is about 5 days later. Now, this young fellow was really happy because this was just for the 4th of July, and he wanted to go swimming. So his question was, can he go swimming with this? And I said, well, we'll see what it does. This is about the June the 26th or 27th. And the next slide. This is what it looked like when he went swimming. Why this oil works, I have no idea. I'm a lipidologist, and I try to keep triglycerides down in the body. I don't want that circulating triglyceride in there. I want it down to normal. And yet it takes triglyceride. Lee Hopkins and I have worked on this a great deal. It takes triglyceride to get these wounds to heal. And yet patients with high triglyceride in the serum don't heal any faster than somebody that doesn't have it. So it has to be the fact that this is applying this oil topically, taken internally. I use the oil quite a bit in my practice. Last November, I was diagnosed with prostate cancer. The scale was a 7, which means it's probably outside the capsule. So prostatectomy or the implants were not going to help me. I had to have external beam radiation. External beam radiation means that the first 4 or 5 weeks of treatment, I had 9 weeks of treatment, the first 4 or 5 weeks, it's more like scatter. They want to get anything inside the capsule plus outside. Well, right outside the capsule is the bladder and the bowel. So that radiation hits the bladder and the bowel also. But it's necessary in order to get those cells that are outside the prostate capsule itself. So you inadvertently develop a irritable bowel. The cramping, the diarrhea, the bloody stool, the urinating blood, the spasm in the bladder is terrible. We do have a product called Omicor, which is omega-3 fatty acid. It's about 98% pure. And I tried that, it didn't work, so I went back to EMU oil. I was using an ounce of it 2 and sometimes 3 times a day, but it did stop that spasm. So it does work internally also in its anti-inflammatory property, and that's what's important. Next slide, please. This is a young fellow. Unfortunately, I don't have the after pictures because this was just taken probably 2 weeks ago. This is a diabetic. He has diabetic neuropathy in the lower extremities. He has very little feeling in his feet. The the patient came in to me looking like this, blood sugar totally out of control. Next slide. There's another aspect of the foot. Has no feeling in his feet. And so this doesn't hurt. But we need to stop this so that, and we actually have. This looks so much better, but I don't have any pictures followed up. Next slide. There's the top of his feet. And we did an occlusive dressing here. We put in the, put the 4x4s soaked with EMU oil, and I actually put rubber gloves on him, on his feet, because I wanted that oil concentrated in his feet. Next slide. There's more of his toes. This was about 4 or 5 days later. The ulcer's underneath, but the skin now is not quite as scarred. He can move his foot now, and he doesn't have the sensation of being so stiff. Next slide. Once again, this is after about a week, 4 or 5 days to a week. I can't remember exactly, but it is starting to heal. And this, the ulcer is under here, but that has also started to heal. Also, if you look at his toenail, he has onychomycosis. So we're now using Lamisil cream in the, it's a topical antimycotic medication that we're mixing with the EMU oil. And the toenail has already started to show some improvement. Next slide. This is a donor site graft that's gone bad. The lady had a quadruple bypass. And she came to me looking like this. Her doctor, the surgeon, had let her go home like this. She's on an antibiotic. He also had her on Silvadene. We had to clean this all off. But this shouldn't be like this. The tissue, the skin edges should be together and should not look like this at all. We cleaned this up and started using EMU oil. I'd like to have gotten it a lot sooner than this, but this is when we got it. Next slide. And this is what it looked like. It was almost 2 weeks. But now we had the skin edges back together. You don't see a great deal of scarring. But this is a marked improvement. Next slide. This one got stuck in here. This is another one that I'm using EMU oil and Lamisil. It's topical antifungal. I'm using it on this page. You see these very cicatricial type toenails. The excessive growth in the toenails. This fellow has been on, I've had the oil on him for about a week now. And naturally, we don't see much improvement yet. Next slide. It's a lady that came to my office. She had herpes zoster, very painful. At an older age, the thing we have to be concerned about here is post-herpetic neuralgia. Because in an older patient, that's what we see, and that's worse than the lesions itself. This is about a week old. I didn't get one when we first started, but this is after about a week after it had blistered. Next slide. And this is about 10 days later. We're still using the EMU oil on this one. I have Paul Benford is the one that producers or I get the oil from. I have the thick oil here. It's actually almost like a salve, and I mix a capsicum in it to get the counter irritant to stop that post-herpetic neuralgia. Next slide. This is my most recent one. This is my nurse. Anybody figure out what happened to her? What do you think happened to her? What's that? What caused this?
It's like radiation.
That's it. She had, well, laser. She had laser treatment for wrinkles. Very attractive young lady.
I can't see her wrinkles.
She had some, but she's a very attractive lady. But she wanted this done, and I'll guarantee you, this is the day after surgery, and she was miserable. And they sent her home with, what's that?
She looks worse than that.
Yeah, she does. I mean, it's terrible the way this, and the doctor sent her home like this and had given her some pain medication, an oral antibiotic, and Silvadene for this. You couldn't even get the Silvadene on it. She couldn't drink. She had to suck through a straw, and even that hurt. Next slide. This is about a week later. Now, her father took this picture, so it's a little blurry. But that's about a week later. She now can eat at this stage. Next slide. It's another one about a week later. I mean, this was a week after the original. But we were using pure oil, 4x4 soaked in oil, and just lay them on. And we tried to put cling on top of that, but it wouldn't work, so she just lay there and not even move. Next slide. That's the face on. This is about a week, maybe 9 days after. It was about a week after the, it looks like here we're going to get some scarring. Next slide. This is about 3 weeks after the initial therapy. There is no scarring. Next slide. This is what she looks like now. Very attractive lady. She was so pleased at this, she begged me for it once she got out of the hospital, because she had been working with me in patients. And she knew what it would do. Her doctor was amazed. But I still can't get him to use it. Next slide.
Does he
Next
still
slide.
have his license?
Yes, he does. This is just another one. You can next slide. That's the one we're using onychomycosis on. This lady had not herpes zoster, but she had eczema. Older lady, she wouldn't keep this clean. This was, in fact, my girls didn't even want to go in and clean this. It was so nasty. But we did clean it off, and this is where we started with the EMU oil. Next slide. This is about a week later, but we don't have any crevices anymore. We don't have any discharge. Next slide. And here we are about 2 weeks after therapy. And she was very pleased. Now she can move her head. Her skin doesn't crack when she moves her head. She was very pleased with this. And once again, this is just EMU oil. I didn't use anything else on this. Just take the 4x4s, soak them, lay them against it. Now I use Telfa, which is a partial occlusion. I don't totally occlude it anymore because I do want some air getting to this. Next slide. These are a little bit out of order. Go 2 more slides. 1 more. This is what it looked like when I first got it. This gentleman had the flesh-eating staph. He went to Lansing and had this, this was all debrided, and skin grafts put in. You'll see some slides here coming up. These are a little bit out of order, but they took the donor site from the upper thigh, and when he came to see me, the upper thigh where the donor site was all crusted. Didn't have a camera that day, but I didn't want to wait, so I went ahead and treated him. It was all crusted. He couldn't move that leg. It was just terrible. You'd push down on it. It hurt. I mean, he'd really stop you. We had him on fentanyl patches, 100 milligram, and that's a walloping dose of fentanyl if you've ever used fentanyl, to stop the pain. Next slide. Or back up 2 now. 1 more. Now, when we started with this individual, I wouldn't put the oil on here. This is where he had the graft. And I'm thinking, this guy doesn't know who I am, and he doesn't know what I'm doing. So I told the patient, you know, you're having more pain where the graft came from than you are with this, because he's also diabetic. And he doesn't have a lot of feeling here, but he could feel where the donor site was. So I put the oil on the donor site. I wouldn't put it here because I didn't want to be blamed if that patch or the graft didn't take. This has only been about a month ago. Now you can go forward. This was, okay, I'll back up just a little bit. He went back to see the doctor, his plastic surgeon, and I was a little hesitant whether to tell the patient, to tell the doctor what we were doing. But I said, okay, go ahead and tell him, because I want him to know what I'm doing. He's a specialist. I'm a family practitioner. I had a little more experience in his wound healing, I think, than he did. So without even telling him what exactly they were doing, he told the patient and his wife, whatever you're doing up here, do it down here also. And then they finally told him what we were doing. Next slide. That's the one we had before. That's the beginning. Next slide. This is about a week after we started applying oil on the lower extremity. And maybe a week or 10 days. Anyway, it was, you can really see it starting to heal. You don't see these very coarse edges here. The clips are now out. You don't see the real sharp edges here that we had before, and there's not near the amount of inflammation. He was very pleased because the skin was much more pliable now. It wasn't like trying to walk on scarred tissue. Next slide. And that was the end of it. Why the surgeon went back and outlined this, I don't know, but he did it. Anyway, he was very pleased. You see the other leg has also had the same thing on it, and we used the oil down here. Next slide. Next slide. This is the other lower extremity. This is when I started using EMU oil. This is after he said, go ahead and do it. So now I could blame it on him if it didn't work. Next slide. And this is about 2 weeks after we had worked on the lower extremity, on the other foot. Now, next slide. This was the donor site. And this is after I used it because I didn't have my camera. And I did not want to, I didn't want to make the guy wait for another day or two. Next slide. But you'll gradually see how this is what it looked like about a week after it's 4 or 5 days after I started the EMU oil. Next slide. This was after he had seen the surgeon. Before we started working on the lower extremity, the lower part of this extremity. This is when he'd seen the surgeon, and he said, whatever you're doing up there, do it down here. Do it down on the graft side. Next slide. Should have shown this one just before we ate lunch. This is another patient of mine that's a diabetic. Not a very compliant diabetic, obviously. She had osteomyelitis in this also. I did debride a lot of the tissue out. I probably should have taken a picture before I debrided it. But we started putting the EMU oil. This patient came to me like this. It wasn't a patient that I did. Now, here's about a week later. And I didn't do any more debriding. You can actually see the bone right here. But go back one slide now. What a difference in a week to 10 days in this wound. And she came to me like this. They had her on everything. They had her on antibiotics. They had her on Bactroban. They had her on Silvadene. They were actually using Crisco and sugar on this one. That's an old treatment for ulcers like this.
Crisco and sugar.
What's that?
I'm repeating, which is Crisco and sugar.
Crisco and sugar. That's the old treatment for bed sores. It did, yes.
It did work.
It did work. Next slide. Next slide. And once again, here's a week or 10 days later. So this obviously works. Why it works, I don't know. I know it has something to do with the triglyceride. It's the combination of the EMU oil. Once again, I try to, especially in a diabetic patient, I want the triglyceride level to stay down. But yet it takes triglyceride to make this thing heal. Next slide. You can still see the bone there, but it is healing now. This is about 3 weeks into therapy. This patient moved after this, but they took a large container of EMU oil with them. Next slide. That's it. This is my first patient. Any questions? Yes.
Before you apply the EMU oil to the wound, do you sterilize it somehow, or do you use it as it comes from the container?
When Paul sends it to me, I assume it's sterilized. When I open that container, I know it's not sterilized. Now, I won't use, whether I'm using the solid oil or whether I'm using the liquid, I will not use the same container on 2 different people. when I start a wound like the diabetic patient or the patient that had the skin graft, I will I'll issue them their own container. And it's interesting that I cannot give it to them. I cannot give it to them in my office and have them carry it out of my office. There's a thing called the Stark Law, that if I own any part of a business and I utilize any of the merchandise that has anything to do with that business, it's a terrible fine. Now, I have patients that can't afford it, or they can afford their insurance. They can't afford their insurance will pay for a medication that I write a prescription for, but I don't want to use it. What I wind up doing is, if they can't afford to buy it, I have 2 drugstores in town that I have some products that I sell through there, and I have pure EMU oil there. And I'll send them down and I'll write a script for it, and the pharmacist knows that if I write the script for EMU oil, that means he's supposed to just give it to him and not charge him. Now, the products I have in the drugstore, I can't charge for, but I cannot give it to them, give that oil to them in my office. I can dress it, I can use it in my office, but the Federal Drug Administration, and via the Stark Law, says I cannot give them. I can't sell it to them, but I can't even give it to them, which I think is ridiculous, but that's the way it is.
But you can't use it.
I use it in my office.
They can't carry it out.
They cannot carry it out. I can, like anything else I have in my office, any topicals I use, any injectables I use, any oral medications that I use. Now, a pharmaceutical company can give me the samples, and I can give that to the patient, and they can walk out with it. But they cannot walk out with EMU oil. I've tried, I've actually looked into getting the oil where I could sell it over the counter and actually say it's for medicinal purposes, but I don't have the millions of dollars to pursue that. I do have a nasal spray that I use called Emethol that I sell in the drugstore. I cannot say it is a nasal spray used for sinusitis, rhinitis. I say it is a nasal mucosal emulsant. I can say that. Or a moisturizer. I can say that, but I cannot say it is for medical purposes. It's against the law. Yes?
On all of these patients, did you use pure EMU oil or did you mix it with something else?
I use pure EMU oil. Now, Dr. Hopkins and I have some products that we work with together that has other things in it, but I predominantly use pure EMU oil. And I apply it. I do a lot of surgeries in my office. I do a lot of facial surgery in my office. And I have the patients, I'll put the first dressing on. And I usually use the solid that Paul sends to me in little containers and have them reapply it. But I will put it on in the office, put the Telfa on top, and send them home with that. And it really makes a difference. I'm surprised that the young fellow with the asphalt burn on his arm, this was very painful. And yet, applying that directly, and I had another, several years ago when I had this presentation, had patients with burns, 3rd-degree burns. Put the oil on and it stops the pain. How that works, I have no idea. It's the anti-inflammatory property, just exactly like the oil taken orally has an effect on the intestinal wall and on the bladder wall. Any other questions? Yes?
Have you had any situation where EMU oil will work with heal neuropathy or have some effect on neuropathy?
I don't know if it's my imagination and this fellow that had the grafts to his feet, and also the new patient that I have that has a diabetic neuropathy, we're using the oil. In fact, I have a patient right now that I just started 4 or 5 days ago that's HIV positive and had his doctor started him on, I don't know why he did this, but he started him on AZT. which does cause a neuropathy. And he, when he walks, he says he's lost the proprioception. Normally when you're standing here, I know exactly which way my feet are pointing. That's proprioception. He's lost that. And he has a difficult time ambulating. So I have him massaging the oil into his feet about 3 times a day. I don't know why they did this. It was done down in Michigan City, Indiana, when he was diagnosed, and they thought he was going to die. So I assume that when they discharged him, they just said, we'll just give you the cheapest stuff we can get, which is old for HIV. And it does have a terrible effect on causing neuropathy. I have a young lady that, uncontrolled diabetic, had a terrible neuropathy in the lower extremities. I've been using the oil on her feet, for legs and feet, for over a year. And just recently, Lyrica came out, which is a prescription medication we use for neuropathy. Also Cymbalta. One of us is getting the job done because she has, I don't know whether it's the EMU oil or it's the Lyrica or the Cymbalta, but she has much better feeling in her leg and less diabetic neuropathy. I think it probably works. Lee and I have talked about this before, and we agree that something's doing something there. I mean, this gal, when I first started using the topical EMU oil, she thought I was great because she had this decreased, or she had lost a lot of the stinging and paresthesia in her legs by using the oil before I started the others. Any other question? Yes.
How would you suggest that we approach the medical community? Here's the situation. We get recommendations from dermatologists. They'll tell the patient, when they've gone through their routines, they send them to us. And we've been real successful with the EMU oil. Colorado State University uses the oil at the animal hospital in the cancer unit.
But they won't use it on humans.
Well, again, we tried to get an endorsement, but I mean, they love the oil. They've already they buy oil every year.
But they're not going to admit to you they're using it.
Right. That's exactly right.
I run into that all the time, and I have friends that are neurosurgeons. I have friends that are cardiovascular surgeons, orthopedic surgeons. They'll send the patient to me, and I'll furnish the patient the oil, but they will not take it in their office and use it themselves. I don't know. I do have one general surgeon that does.
I had carpal tunnel surgery a few years ago, and I put the oil in right after he removed the stitches. Went back in for my checkup, and he says, well, that is amazing. What did you do? And I said, EMU oil. He says, I'll see you in 6 weeks, and walked out of the room.
When I had my radiation therapy back in November, December, the radiology oncologist said, well, the radiation doesn't affect your skin very much. They do give you something, skin moisturizer. He said it doesn't affect your skin very much because you certainly didn't react to it. And I told, now here's one that they are using it. Radiology oncologist is using it. They ordered a bunch of oil from Dr. Hopkins. They are using it to prevent the radiation burn.
So now, here's something, the college won't use it on the animals prior to radiation. They say that the oil causes some kind of a reaction. They get worse burns than if you leave it off. No,
what they don't want is they don't want you putting on just before you go in. But once you started, he was just totally amazed that my skin did not get red. I didn't get even close to what Mary Jo had here. Nothing even close. But I did use it orally for the irritable colon, the colitis, the irritation of the colonic mucosa, and the bladder, because that's terrible.
How much were you taking?
I was taking 2 ounces a day.
That's internally?
Internally, yes. And what I do is I take the pure oil, and I put it in a blender, and I put in some Splenda. And I also put in, I get the vanilla from Mexico, so it's white. And you put in vanilla and Splenda. People say, oh, you know, that oily taste in your mouth. I say, oh, here, taste it. It's almost like taking cotton candy because it does not leave. It's gone. It's just...
That's interesting.
I don't know why it does, but you don't have the oily taste in your mouth. Yes?
I had to have oral surgery on a jawbone, and where a tooth had been pulled, a piece of the bone was working its way out through the skin. My dentist recommended me to an oral surgeon. He took it out. I told the nurse, I said, as soon as I get home, I'm putting EMU on it. You better not. The doctor said, don't do it. But guess what?
I don't know
I
why.
did it anyway, and he was amazed at how it healed.
I don't know why they say that. Of course, the reason, unfortunately, it's money. The reason you don't see a pharmaceutical company pick this up, they can't patent it.
Yep.
That's terribly unfortunate, but if they can't make any money with it, they don't want it. It's just very similar to DMSO, and DMSO does work, but there's no way to patent it. In fact, I've put the two together once in a while for arthritic pain. Yes?
How did you come up with that 2 ounces?
My dad used to say, if a little bit does a little bit of good, a hell of a lot will do a hell of a lot of good. I have no idea how I came up with it, and it did not have any effect on the bowel movements. It did not cause diarrhea. It didn't upset, nothing. I have no idea. I just started. I thought, well, this is what I'm going to do. Yes.
I have a question. Have you, we know some doctors that are using antibiotics in the oil to apply to those kind of wounds. Have you ever done that, or do you?
I've done it.
Gentamicin was one of them that somebody was using.
That's effective. I use Bactroban, and now there's a new form of Bactroban that I will use. I don't use it very often, but I do. If I think it's going to do a little bit of good, then I will do it. But usually it's just a pure oil. And most of the ones that I treat, although I do have infectious wounds that I do treat, but most of them are post-surgery or burns. Of course, those patients are already on an antibiotic anyway. I'm in a city of about 36,000. We have about 30,000 student university. And in the spring, just before spring break, these kids will either go to the tanneries to get their tans before they go to Florida, or they go to Florida and get sunburned. And what I have is I'll actually take a large container and put EMU oil in it, and I'll soak T-shirts in it. And once you do it, they'll stretch. It really softens them up. And I'll put these in Ziploc bags. And when the student comes in, or if he goes to Florida, I say, if I know him really well, take this Florida, when you get your sunburn, just put the T-shirt on. And it really works. It stops the pain. It's much better than trying to rub it on because I've already got suntan or sunburn. So I just put the T-shirts, and somewhere somebody should come up with a product that's a Ziploc. What's that?
Yeah, you need a distributorship in Fort Lauderdale for these T-shirts.
They work.
Sunburn T-shirts.
They work, and they should say sunburn T-shirt on them. Somebody in Florida should do that. Yes. Yes.
Yeah, hi, Dan. Great to see you again.
Good to see you.
Great talk.
Thank you.
I wanted to ask you, you showed the picture of the elderly woman with the inflamed ear. So I wonder if you could just comment a bit more on inflamed skin issues that you likely use it on, whether it's thickening layers of skin, or I'm staying away from the diseases, obviously, you can see why, or inflamed skin irritation either in a wet or a dry area.
All of the above.
Yeah,
I use it in both.
sure.
I don't discriminate between the two because it's going to work on both of them.
And you primarily use the pure oil.
Yes, I use the pure oil.
Because I think we underestimate what the pure oil does, and we always get hooked into this, and a good question over here about the antibiotic. But we really don't need the antibiotic. That's where we've been hoodwinked the last 50 years. We need antibiotics to have healing.
Exactly.
But our regular colleagues are still stuck on that part.
That's the way we were taught. I've been in practice for 34 years now. And when I started into practice, you used an antibiotic. You used it 4 times a day for 10 days. Now we have a medication called Factive that you use 1 a day for anywhere from, for a severe pneumonia, 1 a day for either 5 to 7 days. That's it. But I'm still used to using 4 tablets 4 times a day, or 1 tablet 4 times a day for 10 days. It's just hard to break that habit. Once in a while, if I try to second guess myself, I'll say, well, yeah, this little, I'll probably put a little antibiotic in this one. I doubt that it's doing anything. I really feel, and Lee and I have talked about this a great deal. I think probably it's once again, the triglyceride that's causing something else too, but the triglyceride topically, because that's what it takes to heal. And of course, I'm actually talking out of both sides of my mouth here because I'm a lipidologist. I don't want you to have triglyceride. Yeah, I do too want you to have triglyceride. Just don't swallow it. Anything else? Yes.
Maybe I don't understand enough about triglycerides and fatty acids. It was my understanding that EMU oil has 7 fatty acids in it because we have that breakdown.
There's good fatty acids in it, and there's bad fatty acids in it. The triglyceride in the EMU oil, I think, plus the omega-3 is very beneficial. Omega-3 will actually lower triglyceride. Taken orally, omega-3 will lower triglyceride. Taken topically, triglyceride will actually enhance the healing. Now, triglyceride is not a good thing internally when the serum has a great deal of triglyceride in it, especially in a diabetic patient, because if you look at triglyceride, if your triglyceride is high and your HDL is low, that makes you a pattern B, which is very atherogenic, because that means that that triglyceride is being carried around in the VLDL particle, and the VLDL particle will actually indirectly destroy the HDL particle, which is the one that cleans the artery out. So high triglyceride, I don't care about LDL. LDL is very important, don't get me wrong, but it's not the LDL I'm concerned about in a diabetic. It's triglyceride, HDL, and blood sugar that I'm concerned about in a diabetic, because high triglyceride, low HDL will tell me automatically, and we can do NMR lipoprofiles to look at that. It's like an MRI on your blood. High triglyceride and low HDL tells me immediately that you have small, dense particles, and that's very atherogenic. That's a pattern B, and it's just extremely atherogenic. So topical triglyceride is necessary, but in the system, it cannot get to the surface to where we wanted to do the work.
So what I don't understand is what is triglyceride? I thought there were 7 fatty acids. Is triglyceride part of the fatty acids?
Triglyceride and cholesterol are 2 bad fatty acids internally, in the vessel. Triglyceride topically is important. But internally, in the vessel, triglyceride is not a good thing. But an excessive amount of triglyceride in the vessel is not getting to the dermal layer where it actually has to work to heal the anti-inflammatory or heal the infection.
She's asking, what's the triglyceride in the EMU oil?
I don't know.
Oh, okay.
I don't know. I don't know which.
We know it's there.
I know it's there,
Okay.
but I don't know which. It just comes out as triglyceride. When Paul sends me the breakdown, it's triglyceride.
I'll have to, all right, on the fatty acids, omega-3, 6, 9, those are triglycerides?
Omega-3 fatty acid is not, no, that's not triglyceride. Omega-3 is the important one that is important in the joint anti-inflammatory. Omega-6 will actually enhance arachidonic acid, and that's what causes the rheumatoid problem. Omega-3 will break down the pathway of arachidonic acid. There's just not enough in EMU oil. If somebody could refine it and just get the omega-3 out of there and use it orally, it would be fantastic. Right now, the only one we have is Omacor, which is it's from the salmon off the southern tip of South America, because it has less mercury in it, less impurities. Yes?
Any research been done on topically applied triglycerides affecting the vessel triglycerides?
No, not to my knowledge.
Okay.
And Lee's not said anything to me about it. He hasn't mentioned it to me. Bill, do you know anything about that?
As far as applying it topically,
Does it affect the internal triglycerides after you've applied it topically?
I think you're up to a volume issue.
I was going to say, I think that would
I
probably...
mean, if we look at the most critical omega-3 fatty acids, which are EPA and DHA, those are the ones that are most common in the fish oil, just like the salmon oil Dr. Dean just mentioned, then those are the ones that are useful. How much is needed per day? Well, To get an anti-inflammatory dose for your painful joints, for example, you're talking roughly 10 grams or 2 teaspoons of that salmon oil, because you're trying to get up to 3 grams, 3,000 milligrams a day of EPA and DHA. Now, we know that EMU oil carries things through the skin. You're absolutely correct there, but you would be putting on a great deal. And it's really tricky to talk people into slathering their whole body or 3/4 of their body twice a day for more than a day or two, unless they're getting right out of pain. You know, I, like most people, am kind of lazy. You could likely do it, but it would be a real challenge to get there.
In the areas we use it, we wouldn't be getting enough to penetrate deep enough to get into the vessel.
Because routine now in Britain, they will write, instead of writing many other things when you have a heart ailment diagnosed, they will give you a gram of fish oils, which is the beginning, okay? So that translates to quite a lot of EMU oil, especially if you're only using for the omega-3 component, because it's a fairly mild component, but you could change it. Rather than refining it out, just change what you feed them.
Now, I want to clarify one thing too. The omega-3 that we're using now, Omacor, is the only purified form. Fish oil capsules across the counter, we use, actually I use 4 grams of, in the critical, the patient that's diabetic and really has a heart problem and elevated triglyceride. I would use 4 grams, 1 gram tablets, 2 of them in the morning, 2 at night. If you were to take the fish oil capsules over the counter, you would have to take 20 of them. You would not only belch fish, you'd smell like a fish, and the amount of mercury you'd get would be way too high. So if there was any way to actually purify the omega-3 out of the EMU oil, I don't think it'd be possible. And it'd be economic. I don't believe feasibly possible.
How about the addition of flaxseed oil?
I'm going to pass that one on to Bill. That I don't know. I know it's beneficial.
Well, we can either deal with it now or we can deal with it later when I'm talking, but flax is very, very high in omega-3s. But if you pick up one of these outside, because a lot of the pictures that Dr. Dean showed are in my first book out there, the green one, okay, written in 2000. But in that one, and a better one in this one, is a chart talking about those omega-3s, those omega-6s, because they're the biggest things that's happening in healthcare today. The New Deal is where you're going with your fish oils and where you're bringing down your omega-6 oils. So that's, again, why I want you to start thinking about feeding. There's a very sophisticated way to bring up the omega-3 fatty acids in eggs, in broilers, in hogs. They feed them 10 to 20% ground flax. Okay? Pretty sophisticated, but it's omega-3, but it's the basic essential fatty acid omega-3, meaning the one that we need in most of us, and then our body will make it into the EPA and the DHA, which are the ones that we use so much in our brain and our heart health, every cell in the body. However, we all vary as to how well we take it down that pathway, how well. At best, we convert about 5% of what we take into flax oil, the alpha-linolenic acid, down the pathway. So that's not that much. If we're eating way too much omega-6, and I'll go into this again later in a mini review, then that really reduces even further, because they compete with the same pathways with the enzymes. Okay, so that's a really important thing to get a hold of, because if you get a hold of this, you'll be ahead of your healthcare practitioner. Not that hard.
People that see what I do with the EMU oil are very amazed, especially doctors, but I haven't convinced them yet. Some I have, but not over the board. I haven't. I would think they'd jump at it and start using it, because it makes their incisions heal much better. Yes?
We still have some people confused about triglycerides. Let me say this, and then if I'm wrong in place, please correct me. Triglyceride is glycerin molecule with fatty acids attached to them.
That's right.
And they attach 3 fatty acids to that one glycerin that makes a triglyceride. So what he's saying here is that when you're putting that on, you're putting on the EMU oil that has triglycerides made with omega-3 and so forth fatty acids, but it always occurs in there as 3 flat fatty acids attached to one glycerin molecule, and that is a triglyceride. So that the deal we're dealing with here is the fact that the triglyceride is a good one because it's got all these good fatty acids attached to it. That's where the triglycerides are involved.
Triglyceride is a backbone.
Yes.
That hooks these fatty acids. Yes.
It's just a carrier molecule,
It's a
basically.
skeletal backbone.
And you put a whole bunch of these triglycerides together in a chain, and you have a fat molecule instead of a liquid oil.
And you can have a short one,
Yes.
like butter, which is roughly 4, or you can have a great long one, like fish oil.
Yeah, because that fatty acid is simply made of a chain of carbons. And you know, you remember on the analysis sheets, it tells you how many carbons. Well, the number of carbons determines which fatty acid you're dealing with. And so the fish oil ones are big old long ones, and some of the other short ones.
He's a retired science teacher.
Yes, I was talking to him a while ago about this. Yeah. Yes.
Yes, Peter told us they've been trying the flaxseed in South Africa and find it to cause instability in the oil. So before everyone starts doing flaxseed in their diet, we need to find the proper antioxidant to stabilize it. And we'll for sure let you know. But just a caution, don't change your feed formulas yet.
There's actually been a feed study done where they were feeding flax to him, and it does make it unstable oil. So we know that from past studies here in this country too, so y'all be cautious on that.
I can testify that I actually did that, not with just a few birds, but with a whole bunch of birds. We added 50 pounds of ground flax per ton, and I increased the omega-3. When we refined it, it increased from 1% to 4%, but we did lose the stability of the oil, of which I sent all back to Paul Binford to have it rerun because it just smelled like a real fatty oil. We also tried another high-fat feed, taking our 3% fat finisher up to 6%. And, you know, after our bad experience with flax, we went to a vegetable oil. We did increase the omega-3, not as much. It went up to about 3%, but we still had a real hard time getting an OSI reading that was stable enough. So this year, I'm back to my regular finisher feed.
No, good for you to have studied those because it's an important issue. You need to try and determine where you want to market your EMU oil to. We know that EMU oil works with or without high omega-3 fatty acids in it. The typical, when most of our rations, if you measure them and you go back and look at them, they will have somewhere between 0.5 and 1.5% omega-3 fatty acids in it. 1.5 starting to get up there a little bit, a little more at risk. Let me tell you a deep, dark secret that all the oil manufacturers worked out about 40 years ago. That if you put on the shelf omega-6 fatty acids, corn oil almost completely, safflower, soybean to a great degree because it's mostly omega-6, they will keep on the shelf for years. That's why all the omega-3s disappeared from the shelves because they didn't keep worse spit. Downside, most of us have 16 to 20 times omega-6 in our diet as 3s, and that's one of our individual poisons that we swallow every day and we purchase because it keeps so good. So if you want to keep your EMU oil a long time, don't boost the omega-3s in it. So the key thing is omega-3s have their own special value, but keeping is not one of them. It might be a great thing in a capsule where you seal it right away and you don't taste it, or you might put in that capsule or some other variation thereof a lipase molecule or enzyme which helps break it down, because nobody likes to burp not great flavors.
Yeah, see, that oil is held for about 3 weeks. You know, between the time it's refined till the time that it's tested and released. And he was barely hitting a 10 on the OSI reading, which is the minimal amount that he would accept to certify the oil.
But where did certification came from?
And then it deteriorated rapidly from there.
I mean, I was on the EMU oil standards team when we did it, okay? And where did certification of stability come from? It came from the oil seed industry. They wanted it to keep good. It worked awesome. So let's rethink. what we're applying it for and what we're using it for. If we're thinking a capsule at the end of the day, then we need to think more omega-3s. All right? If we're thinking long-term stability, because it's probably, this is from the 1996 patent by the Forest Scientists out of Australia, it's probably not the fatty acids that are doing this special thing in emu oil. Okay? So let's compare apples and oranges. That's all. But you're absolutely right. It doesn't keep us good.
Hi, Dr. Dean. My name is Richard Guy from North Carolina. It's my first time here. Spent a little time with Dr. Cote Day at lunch. Address a couple things. What kind of address was you talking about research? My company's experiencing that right now. We're dealing with the medical community. For you guys don't know me, I make Blue EMU, and you see it in Walmart and everywhere in the world. We also make a scar product called Transdermis. Our oil comes from Paul Benford as well. We've got 500 physicians across the country right now in their offices using EMU oil. It's taken us about 2 years and a lot of money to get in those offices. And we're not selling it. Only place you can buy our product in the country right now is CVS, or maybe Rite Aid, Mary. CVS drugstores around the country carry Transdermis, which is pure EMU oil. The challenges we've been up to is the same thing everybody in this room is facing, is bringing credibility to the oil from the medical community side. We all know it works, but trying to get that message across to the American public where they can buy it is another issue. We've run an IRB study, Institutional Review Board at Albany Medical Center has been in process for on 2 years, a human study. Dr. Jerome Chow is involved with that, but what our focus is on scarring. I hear a lot of people talking about essential fatty acids and cholesterol and flaxseed oil, and we talked about this today for a couple reasons. That's the wrong way to go. I mean, for all of you in business, I know the capsules are great. First of all, if it got big, there's not enough birds in the country to supply it. And that's just a straight math problem. Because we looked at it. We looked at selling it in gel caps and nationwide and worldwide. And then in the day, you've got other products out there right now that are performing better until the research is there. The area where our company's going to try to grow this business in this industry is after burns, scarring, inflammation, pain, which is a big industry right now, and it's growing because we're all getting older. Everybody hurts, and it's a good market. So our focus from the standpoint is research. There needs to be more research done, more human trials done. It needs to be published research. That's the big thing. We're in the process of getting some things published. Our company's got foundations out there to hopefully, get involved with the AEA and some other, and try to further this along, further. But anyway.
I'd like to discuss this further after. How's the
Myra has a question.
how's the transdermal? How's it supplied? Is it in a dressing?
It's an eyedropper.
Oh, okay.
Just like it's a 1 ounce vial from Paul. It's moving okay at CVS. When it goes down the end of the day, it's all based on marketing and marketing dollars. It takes a lot of money. Our company, I fight every day against Procter & Gamble and Chatham, and you're dealing with Chatham's money right now with Icy Hot and Ben Gay and those guys in the world market. Mm-hmm. I could tell you that our product right now, from an EMU standpoint, is number 10 in the country. It's the only EMU product in the country that's ranked in the top ones.
For pain cream.
For pain cream, yeah. The scar product's the future, because I think that we talked about earlier at lunch, getting the protocol and the studies done based on inflammation and those basics, we know that works. There's already a lot of stuff done. But getting into human trial and these testimonials, these photos, that's how you're going to get it published and get it out there and get the medical community behind it.
Mm-hmm. Question.
Dr. Dean, I was just on a more personal note here. What percentage of your patients do you think that you use EMU oil on for their wound care?
I see roughly 30 to 40 patients in a day, and it's on Fridays when I do my surgeries. I'll see probably myself see 20, my PA sees probably 30, and of those 20, if I do surgery on 10 of them, they're all 10 going to walk out with EMU oil. Now, on a general day, I'm either refilling the EMU oil or I will start EMU oil on probably 1 or 2 patients on an average day.
But you're doing it for almost all wound.
All wound.
Okay.
Not only lacerations, but all wounds. Yes. Any other questions?
One more. Inward.
This is more on a personal level again. My sister has high cholesterol, and I started her on EMU oil gel caps. Well, she was doing real well on them, and then all of a sudden her triglycerides went out of this world, and she blamed it on the gel caps. Could that possibly happen?
I don't think so, but I'm going to pass that one off to Bill again.
This is past the buck then.
He's going to lecture on this in just a little bit.
You see, we're partly hooped with EMU oil gel caps because we don't know how. We've got the one article showing that it works virtually as well as a really good quality olive oil. EMU oil, if you look at the numbers, and you can look at the chart in here comparing it to all the other oils, is really high in monounsaturated fatty acids, okay? That's the omega-9s. We can make those. That's not a true essential fatty acid, okay? Probably there's another disease process happening with the triglyceride boost, almost for sure, I guarantee it. But you can't prove it to anybody because we don't have a mechanism yet to show how the EMU oil works. So we're kind of hooped. And that's one reason the docs are covering their backside so very, very carefully, because they want a mechanism. So as closer we get to the research to the mechanism. But I agree completely, you know, what the gentleman here talked about, you know, the topical applications, and very much as Dr. Dean has done. The topical, we should be thinking of more so, and we'll talk about the reasons why later. It almost for sure didn't happen, you know, that it triggered the cause, but we can't prove it. And we can't prove the interaction between it and some of the other things she was likely on to might have triggered it. But more than likely, there was something new went awry in the liver. And we've got a new disease today. We have liver failure from high fructose glucose corn syrup in our pop, soda pop.
Yes.
All right? And now we got a drug to treat it. So there you go. So there's a number of things will rocket up your triglyceride, but there isn't acceptance and awareness yet. So, but you're stuck in the room, and you may be one of the guys because you're stuck in the room using it.
I would like to make one comment, and then I'm done here. If we're going to try to treat or compete with the Omicor with EMU oil, we're not going to get there because that's 98% pure omega-3. And it is very effective in lowering serum triglyceride. It will raise HDL some, but any patient of mine that has had a cardiovascular event or an impending cardiovascular event are going to be on Omicor, 2 tablets twice a day, and there's no way that EMU oil taken orally is going to compete with that. Thank you very much.